Good morning, distinguished panel members. My name is Dr. Kathy Platoni. I am a clinical psychologist, a colonel in the United States Army Reserve, and I am the Army Reserve Psychology Consultant, which you loosely translate to Chief Psychologist for the Army Reserve. However, I am here today as a civilian practitioner with substantial human experience in both the civilian sector and in the wartime theaters of both Iraq and Afghanistan. It is my belief that we must absolutely maintain the right to use CES for our private patients, our service members, and our veterans. In my experience, without exception, there simply is no more powerful form of therapeutic intervention, either as an adjunct or as a standalone treatment than Alpha-Stim CES. It is incumbent upon me as a practitioner to offer all of those treatment interventions that may affect positive outcomes, all-inclusive, hence CES. In the wartime theaters of both Iraq and Afghanistan, and under the worst possible conditions that any human being should ever be forced to tolerate, Alpha-Stim CES was the single most effective form of treatment that our combat stress control team was able to provide to service members in our care. In terms of insomnia, CES was the best form of treatment we had to get soldiers to sleep, where sleep is elusive. The use of CES spread to other practitioners once they viewed such positive results. In terms of anxiety, nothing worked better to treat anxiety than CES, and again, under the most stressful conditions imaginable. In the face of desperately depressed soldiers consumed with overwhelming misery and despair, the rapid and progressive effects of CES made it possible for these soldiers not only to perform their missions, but actually to exceed standards and expectations. And with respect to PTSD, most importantly, soldiers were able to remain on mission. To deny access to CES will result in tremendous and unnecessary suffering among infinite numbers of patients who prefer not to shuffle through life stuperously as a result of medication side effects.
Hello, I am Dr. Brian Earthman. I am a psychiatrist. I'm also the medical director for Electromedical Products International. I'm also a major in the United States Army Reserve. I am not representing the Army Reserve today. I'm representing myself, so the comments are for me. As a practicing clinical psychiatrist, and 90% of my time is spent doing that, I need tools to treat my patients. The recent practice guidelines from the APA, American Psychiatric Association, for treatment of depression gave us information that shows that at 12 weeks, people who had initiated medication treatment had stopped their medication and they had not remitted, all right? And basically what we know now is that we need more tools, okay? CES is one of those tools that's effective for me in my practice, okay? At this point, I've treated over 300 patients with CES, both in my outpatient practice, also in a theater of war in Iraq, and it's been extremely effective. I feel much more comfortable treating patients with CES from a safety standpoint than with medication. Point was brought up earlier about treatment of insomnia in theater. That's one of the great benefits for this treatment, is that a CES treatment will not leave you sedated and over-medicated. You actually feel more relaxed and alert after a treatment, so I don't have to worry about those potential side effects that come along with a lot of the insomnia medications.
Good morning. My name is Scott Elder. I'm Vice President General Counsel for Electromedical Products International, EPI. Currently, our largest customer is the United States government and state governments, followed by China and Europe. As you can see in this slide, EPI's government orders have increased dramatically over the past 5 years. Currently, EPI sells over 1,000 devices per quarter to the U.S. government, and our U.S. military market grew 57% in the past year, helping establish the effectiveness of the device. The U.S. military's use of CES is primarily for anxiety, insomnia, depression, and PTSD. This graph also highlights a continual growth in utilization of Alpha-Stim CES with service members for those primary indications. This chart provides numbers which were graphed for you in the prior slide, again highlighting a continual increase in utilization of Alpha-Stim CES over the past 5 years by the U.S. Department of Defense for the treatment of depression, insomnia, anxiety, and PTSD, which FDA acknowledges in its executive summary is a form of anxiety. In 2010, the Pain Management Task Force of the Office of the Surgeon General for the U.S. Army listed CES as a Tier 2 modality in its standard of care protocols, highlighting the acceptance of CES within the U.S. Department of Defense. 3 colonels who were a part of the task force were users and prescribers of CES, and they were instrumental in CES's inclusion within the guidelines.
Okay, I have mentioned before we provided you with a letters book. However, I also encourage you to look at the letters that were marked "Do Not Post." We got those through the Freedom of Information Act, except some people sent us letters. One of those people were a colonel on the co-chair of the PTSD task force for the U.S. Army, and we had been included in the standard of care in 2010. It was published under the pain guidelines. It left the final committee, like this one, for PTSD to be included as the standard of care. When it was printed, it wasn't that way. And, well, I'm going to just say, Colonel Lowry, you have a letter from Colonel Lowry, who you're welcome to call and discuss this with, and he's pretty upset that the committee decided something and then whoever didn't print it, took it out in the printing. In addition, we have provided you with information on usage in the military. And what you can do, if you're based here, is just go down the block to the National Intrepid Center of Excellence at Bethesda Naval Hospital, which is the PTSD and TBI center for the Army, for Tri-Forces, for the military, on the grounds of the Bethesda Naval Hospital. It's the National Intrepid Center for Excellence, built and donated to the U.S. Army, to the military by the Fisher brothers. And that facility uses Alpha-Stim on every single soldier going through the facility. That's 100%. And understand, there's no way we can sell them on doing that. It has to work, or they wouldn't do it.
Dr. Dallas Hack, the director of the Combat Casualty Care Research Program for the U.S. Army, has officially requested that the FDA perform an expedited review of CES reclassification. He has also formally expressed the Army's desire for CES devices to remain available to treat soldiers.
Thank you for this opportunity to speak to the panel. My name is Steve Xenakis. I'm a psychiatrist, former Army Brigadier General, Medical Corps officer, served on active duty for 28 years. I have a part-time clinical practice and consult with the Department of Defense and other government agencies on neuropsychiatric conditions. CES is safe, practical, necessary, and effective. As a senior advisor to the former chairman of the Joint Chief of Staff, Admiral Mike Mullen, I was his advisor for several years. And I applied some principles for assessing promising treatments and getting them into the field expeditiously. Remember, we have been at war for over 10 years. And many of us who served during the Vietnam era have been committed not to see the problems that followed that long war happen again. These principles of safety, efficacy, practicality, and cost benefit. Regarding safety, these devices have been used for more than 3 decades, as you've heard. There's no record of significant or dangerous adverse events, including seizures. There are no serious side effects caused by CES, and the incidence of minor side effects, such as headache and skin irritation, is low, and the effects are transient. At times, over the past 30 years, the FDA has lumped CES with other electrophysiological devices such as ECT and RTMS, but recognized for this hearing, they have made a distinction. But as you've also heard, CES is much safer than either ECT or TMS. Next slide in terms of efficacy. As noted, no treatments for PTSD or mild concussion are identified by the Institute of Medicine as substantially effective for soldiers and veterans. There is no gold standard, in fact, when we come to our clinical practice. We have heard today that the scientific on CES data, the scientific data, while not perfect, does show significant evidence of effectiveness. We've had top-tier academic psychiatrists prescribe the devices. They are widely used because they are effective and have been for decades. The research shows that there is a biological effectiveness in the increased levels of CSF serotonin and beta endorphin, as well as plasma levels of neurochemicals. I do believe strongly that requiring the companies to conduct studies in accordance with a pre-market approval would put them out of business and essentially deny care to soldiers and veterans. This is unacceptable. CES is a practical treatment, as the patient can use the device in the privacy of the home setting, and you've heard in the combat arena, in the theater downrange. It does not require frequent or intense visits to a practitioner's office. CES is not costly as compared to other treatments, either ECT, TMS, many medications, or alternative treatments, including interpersonal therapies. The military recognizes the benefit of CES in the treatment of soldiers and veterans. As you know, the panel has a letter dated January 13th for reclassification from Colonel Hack, the Director of Combat Casualty Care Research Program at Fort Detrick.
Dr. Brian Earthman. From a clinician standpoint, in response to your question about what types of insomnias are responding to CES treatments, as a psychiatrist, if you will classify it into initial, middle, and terminal insomnia, I see response in all three of those categories. That's one way to look at it. Another is by specific disorder type, mood disorder versus anxiety disorder versus substance use disorder. And from a mental health perspective, I have not seen a type of insomnia that did not respond to that. Obviously, an obstructive sleep apnea type of insomnia, this device isn't going to be as effective with that. But in looking at it in those two types of ways, I've definitely seen a response there. In addition, in extreme environments such as a combat zone, we're able to see. So it's not just mild insomnia, it's significant, severe. Additionally, I think on the insomnia point, when you do a treatment, as soon as the treatment's done, you're alert and you're ready to go. That's why you don't do it right before sleep, as opposed to some of our other therapeutic options, which will create windows of time, such, sleep medications, 8 to 10 hours sometimes, where you really don't want to be doing significantly intensive tasks, such as operating tanks or helicopters or probably even driving.
So I've heard several people refer to the fact that the military is using a lot of these devices, presumably, and just sort of focusing on the depression, anxiety, insomnia, not on pain and other things. Can anybody give me figures on how widely it's used, is sort of the first part of the question. And I've also heard reference to the fact that there's lots of people who've come back from Iraq and Afghanistan with anxiety and depression and post-traumatic stress disorder, and the Institute of Medicine has not endorsed the use of antidepressants, for example. But are there any military or VA guidelines, reports, consensus reports that have said that CES is useful for any of these conditions? Because I'm not aware of any, so I'm just wondering if I just don't know about them.
That's why I urge you to talk to Colonel Lowry, the co-chair of the PTSD task force. He will tell you that it was supposed to be in there, and it's not in there, so we've got politics at play. I don't know the reason.
In terms of combat situations in which any number of psychological emergencies might arise, we used it extensively to diminish hyperarousal symptoms, to diminish symptoms of panic, to improve sleep across the board when people were too exhausted for being out on mission and being unable to sleep for days on end consecutively, in order to get them to sleep, in order to allow them to go back out on mission. So in essence, the use of CES in the combat theater, in my experience in both Iraq and Afghanistan extensively, is that CES is a force multiplier. It allows soldiers to function without the benefit of medications that might impair them. And again, there's that waiting period between taking the medication and going back out on mission. And sometimes you can't wait. You can't predict when you're going to come under attack. So again, CES has been a force multiplier across the board in my experience. Thank you.
This is Steve Xenakis. I'd just like to answer Dr. Stein's question here about the military's endorsement, I think is the way. And I know you probably have looked at a lot of the literature that being collected by the Department of Defense. In fact, the guidance for the treatment of PTSD and IED blast and pain is very general and in line with people using best clinical judgment. There are, as you saw, 4 studies being done within military settings.
Oh, yes, sorry.
Yeah, I
Go
mean,
ahead.
the VA, there are clinical practice guidelines that have been developed by the VA and the DoD conjointly. And they have clinical practice guidelines that speak to the treatment of major depression and PTSD, and they're publicly available, and I just pulled them up on the website. I haven't gone through them in detail, but I know the PTSD ones pretty well, and as far as I know, they don't refer to the use of CES.
That's why I urge you to talk to Colonel Lowry, the co-chair of the PTSD task force. He will tell you that it was supposed to be in there, and it's not in there, so we've got politics at play.
Last
This
question.
is kind of tied in. It almost sounds like, from what you're describing, that the military is conducting a open label effectiveness study, so to speak. And I'm just wondering what type of registry is going along with this, what sounds to be almost like endorsement of this particular product, and what type of safety endpoints are they following? For example, are they following worsening of the condition being treated as a result of ineffective treatment, since that would be one of the most concerning of potential risks?
Again, I have met several times with both Colonel Hack and Colonel Castro, who are funding, their offices from Fort Detrick are funding these studies. And since we are not directly involved, and I will then defer to EPI if they're involved, that information is not, they're keeping that with private and has not been disclosed to us.
Just along those lines, I was struck by the lack of research being conducted by the DoD, given those graphs on that the use is skyrocketing, and it just seems that there would be some interest on the part of the DoD to conduct those studies. And it looks like all of the effectiveness studies were conducted so long ago, and there doesn't appear to be a match between the use of it and the number of studies being done to evaluate it. So that sort of raised a red flag to me.
Dr. Good?
Well, I think that's an important point. We did hear that there are some ongoing studies, not a lot, but there are some DoD studies that are ongoing. Unfortunately, we don't have that information, and one of our charges is to make a decision based on the information we have available at the present time. That's unfortunate in some ways, but that's our charge. Just to close off the safety issue, I personally am convinced that this is a safe device based on all the comments the colleagues have made around the table.
Yes, Dave Miller. Also, I'd like to point out too that even though, the best case is this fantastic clinical study, the CFR does allow us to look at reports of significant human experience. And in our documents, we have pages of significant human experience, including generals, captains, corporals, I don't remember all the ranks, saying how the military is using this on the battlefield, in the hospitals there, as well as when they get back. That I also think speaks reams of efficacy data showing a good effect. And I agree with everyone here saying there is no safety concern. Thank you.
Yeah, I think it sort of underlies the risks of relying too much on testimonials because, during the break, I went and talked to several colonels in the active Army, and they told me, and I told them what had been explained, and even the people that were said to have said those things. And I got back, a colleague at Walter Reed who said, I checked with people in the outpatient psychiatric clinics. This is rarely being used. I wasn't able to get a hold of Jim Kelly at NICoE. He hasn't responded yet. I asked about in-theater use, and he asked as many psychiatrists as he could get a hold of in the last couple of hours, and he said he's not aware of anybody who is using it. Now, so maybe there are other groups of people using it, but I don't think we can put too much stock in testimonials.
He had emailed or talked to colleagues in the armed forces, and he got some information back but couldn't get quickly enough. There is a Colonel Pastel here from the armed forces who is willing to discuss what the experience of the military is as a follow-up to Dr. Stein's earlier comment. So I'm just wondering if Colonel Pastel could make a comment regarding the military's experience per what Dr. Stein had talked about earlier.
I think at this point, we're not any longer open to public comment. So let's hold off on that.